Okay, welcome. Thank you. Thank you for joining us. I'm Andy Kaytes, and I am here with Dr. Jordan Lake. She's from the University of Texas, Houston, and she is the expert for us today when it comes to metabolic issues. So, welcome.
Thank you.
And are you enjoying the conference so far?
I am. CROI is always full of excitement and busy and lots of new things to talk about.
Yeah, and you have a couple of posters here.
I do.
736 and 737
Correct.
for those that want to look them up. And can you tell us a little about 736? Let's start with the tesamorelin.
Sure. So both of the posters actually talk about fat density and what we can learn from fat density, which is really a measurement that we find on imaging like CAT scans or MRIs, and it tells us something different, we think, than the quantity of fat. So normally when we get a CAT scan or an MRI in the research setting, we're seeing how much fat does somebody have, and we think that tells us one thing, more along the traditional lines of obesity or not having enough fat and malnutrition. But we're starting to learn that fat quality is very important too. And your fat, no matter how much you have of it, it needs to be functioning well. And the density on the imaging is a measure of how well the fat is functioning.
Interesting. So we all have fat.
We all have fat.
Hopefully.
It's the largest organ of the body. We have more fat than just about anything else, even
Wow.
the thin people.
Wow. I'm mortified now. But the fat that you're talking about, is it the kind that you can pinch? Or is it deeper than that?
It's both kinds. So the fat you can pinch, we call subcutaneous fat, or the fat under the skin, and the very deep fat is we call visceral fat, or the fat around the organs. And both of those kinds of fat we want to work well, and both of those kinds of fat you can assess with imaging like CAT scan or MRI.
Interesting. So tesamorelin works mainly on the visceral fat, correct?
Correct.
Okay, and what is tesamorelin anyway, for those that don't know?
So tesamorelin is a growth hormone releasing factor analog. So it's a medication that stimulates your body to release its own growth hormone, which is thought to be a more natural process than taking growth hormone and have fewer side effects than when several years ago we were trying to see the benefits on fat of taking growth hormone directly. And it's approved by the FDA to reduce visceral fat or fat around the organs in people living with HIV. It's the only drug that has that indication. And so we care about visceral fat because really the associations are that as you accumulate visceral fat, your risk for heart attack and stroke goes up, and your risk for diabetes goes up. And so by reducing visceral fat or preventing its gain, we may be able to prevent other problems down the road.
Interesting. So the one caveat to that is that once you stop taking the tesamorelin, the fat doesn't stay off necessarily?
Correct. Your body's trigger to keep producing that growth hormone, which is keeping the fat from accumulating, is gone when you stop taking tesamorelin. So that's one limitation of the drug. But about 60% of people who take it do have a good response, and most people, I say, would stop taking it because it's an injectable agent, and getting shots, sometimes you get tired of that over time. But if someone's willing to keep it up and not getting tired of giving themselves the shots every day, you can continue to take it and continue to see results if you're somebody who had a benefit from it before. And what we wanted to look at with the poster is we know that it reduces the quantity of fat. That was what the company was looking for when they submitted it to the FDA. We know that reducing the quantity of visceral fat improves your risk for heart disease and diabetes, but what does it do to the quality of the fat? And so that's where we come back to looking at the density of the fat. So the original studies of tesamorelin had CAT scans where they looked at the quantity of the fat. We went back with the the radiology team and looked at the CAT scans again to measure the density. And so when we're thinking about fat, it's as easy as, oil and water separate and fat floats. And so anything that floats is not very dense. And so we think about fat as being a not very dense agent, substance. Whereas when fat can become more dense when it has scar tissue or other, or it's inflamed or other ways which things are kind of in the tissue replacing just the fat itself, the actual lipids. When that gets replaced with anything, the density can increase. That's the unhealthy way to increase your density. And it's sort of a complicated subject, but the fat can also change in healthy ways, the density. So when you gain weight, because you're gaining fat mostly, your density is going down. It's because because each fat cell is getting more and more fat inside of it.
Okay.
So as it gets more and more fat, it gets less dense. When you lose weight, each fat cell shrinks. And by getting less fat inside the cell, it becomes more dense. And that's considered the healthy way to change your fat quality. So with the Tesmorelin studies, as people were losing their visceral fat, what should happen is those fat cells should get smaller and therefore more dense, and that should reflect a healthier fat cell.
Interesting.
When fat cells are really swollen and full of fat and lipids, they're not getting enough oxygen usually, they're stressed out, and that is considered like a pro-inflammatory state. That's what we see with traditional obesity. And so anything you can do to normalize that should improve the function of the cell. So while density can fluctuate, when you're giving an intervention that reduces the quantity, what you want to see is the size of those cells decreasing, the density for increasing, and that would reflect the fact that we believe that the fat cells themselves are becoming healthier with the medication.
Okay.
And we see some reductions in the inflammatory biomarkers that go along with that. And so that's another key to us, that the fat is getting healthier with Tesmorelin compared to placebo. And additionally, we control in the analysis, we control for the amount of the fat. So the fat is getting more dense at any given quantity. So that means sort of no matter how much you started with, you still had the capacity to improve the fat quality. And it also can mean that two different people, who have the same amount of fat, they can have different densities, and the person with the smaller fat cells will have the greater density, and presumably their fat will be functioning better.
I see.
And therefore, they will also have a lower risk of heart disease and stroke and diabetes. Now, these studies aren't long enough for us to be able to say that the folks on Tesmorelin had fewer heart attacks and have fewer strokes, but we can extrapolate from what we know in the general population and the large cardiovascular health studies to say that we should see that kind of benefit if people were on the drug longer terms.
And this all fits into the overarching metabolic issues, family of everything,
Correct.
I guess. So we know that the HIV medications can work to redistribute fat. Moreover, the medications that aren't being used as much today, but HIV, I understand, can also do that.
We believe the virus
Lipodystrophy
directly has some effects on the fat, and so there we see traditionally the movement of the fat from the subcutaneous space or under the skin into the visceral organs, which is again associated with increased risk for cardiovascular disease and diabetes. We're not looking in this case with the tesamorelin, we're not trying to reverse that kind of process or anything like that. You're just trying to improve the fat that's there and the health of the fat that's there. But it was a great insight. We were really happy to see those results, that we think that the function of the fat is improving. That really gives us a signal that we're doing something beneficial for our metabolic health overall by giving tesamorelin, and so that's positive. The density issue that we see on the poster, I just spent a long time, trying to explain it. It's a complicated issue, and we're just learning about fat quality in HIV. It's a new concept, so there's a lot more to learn, but those findings were really promising to us in terms of believing that in addition to reducing the quantity, we're really doing something to improve the health of the fat.
Yeah, that's really interesting to me, because if you think about, as a layperson, you maybe order a steak at a restaurant that might have fat on it, and you can understand that the meat came from a muscle, and that's a moving, useful tissue, and you look at the fat and you just think it has no use other than just sitting there,
and tasting good.
Remember, you're at the University of Texas. They have
Yes.
they have beef there.
We have plenty of beef.
Yes. So so the fat doesn't just sit there. There are mechanisms within the fat that your body utilizes. Apparently.
It needs it.
So,
I mean, fat is food for the other organs, and muscle. There's always muscle around fat, and that helps protect the muscle, and the muscle, it interacts with the muscle, but there shouldn't necessarily be fat inside the muscle, right? And when we have a steak, we like to see fat that's gotten inside the muscle, because
the marbling.
The marbling, that means the steak is going to be juicier and more tender, and that's good for eating. But for function, we're learning that actually fat inside the muscle may reduce the function of the muscle, because muscles are not supposed to be tender and loose and juicy, right? They're supposed to be strong and hardworking. So also fat where it's not supposed to be is a problem, and in that case, being inside the muscle is one place where it's not really supposed to be.
Excellent. Well, and I guess we're going to have to apologize to the vegans that might not understand the analogy of the fat, but anyway, Google it. So lastly, on this issue, does the visceral fat affect women more than men, or men more than women, or equally? Do we know?
I think in the modern era, we're really reassessing that statement with new HIV drugs and their potential effects on fat, especially visceral fat, and a growing obesity epidemic, the way those things come together. I think whatever we used to say about lipodystrophy specifically, where women were maybe more at risk of central fat gain in some studies, we don't see that specific syndrome as much, like a really clinically apparent with the new people who are started on the new drugs and never and move forward from there. So we're really reevaluating what the risks are.
Okay.
There are some studies, like ACTG 5260 was a metabolic sub-study of an ACTG study that folks were randomized, everyone got Truvada, and then people were randomized either to get ritonavir boosted atazanavir, ritonavir boosted darunavir, or raltegravir in addition to the Truvada. And there's, in subset analyses, there's some suggestion that maybe women gained a little bit more weight or visceral fat on the raltegravir arm, but there are some very specific limitations to that study. Again, that was only in subset analyses. The overall study showed that on the CT and in everybody was gaining the same amount of fat, no matter what HIV medication they were on. So we really probably want to focus on those more objective findings from the overall study and not the subset analyses that look at smaller groups of people. Some people do tend to gain more fat than others, and on the newer regimens, especially the integrase inhibitors, that's something we're trying to understand right now. So I would say it's not completely clear, and nothing's cut and dry. Overall, with newer regimens, we're not as worried about that visceral fat accumulation as we were with some of the older drugs, but some people may be at risk, and we really need to do some more careful studies to figure out what would put an individual at risk for that.
And I imagine host genetics have a role to play in this as well.
Probably a huge role that is probably the most poorly understood, I would say.
Yeah. Isn't somebody also looking at tesamorelin if it has any kind of impact positively or negatively on cognitive issues?
There's an ongoing study, I believe. I can't speak to that exactly because I don't know the details of it, but I know there is an ongoing study to see if tesamorelin can have beneficial effects on cognitive function. And there's some evidence for that, again, in the general population where visceral fat is associated with worse brain functioning. And so that's, again, from the traditional obesity setting, the traditional diabetes setting. How that's different in HIV, we still need to work out and understand, but I think that's a really interesting study, and I'm not part of it, so I don't know as many of the details, but I look forward to those results.
Yeah, maybe we'll see it at the next CROI or one after that. Okay, so moving on to your other poster, 737, and that is more to do with cardiovascular issues and the quality of fat, or? That's
another quality of fat poster. So that uses some data from an ACTG study that was completed a number of years ago, ACTG 5224S, I think, the sub-study of A5202, and that was a sub-study where people actually had fat biopsies and CT scans. And so we previously showed that the CT scans really did reflect what was happening at the individual fat cell level. And I thought that it was really important to prove that because it had not actually been proven in humans. It was extrapolated from animal data, and people assumed it would be true because it makes sense that it should be true. And no one had looked at it in HIV before, and whether you're on treatment or off treatment, I thought, well, we better just be sure. So last year at CROI, we presented the comparisons of the biopsies to the CT scans, and we showed that, yes, those smaller adipocytes that have less fat inside of them, they are more dense on the CT scans, and the bigger adipocytes that are just stuffed full of cholesterol and lipids, they are less dense on the CT scans. So we said, okay, we've shown that we can really use these CT scans to tell us about the health of the fat. Let's look at some other, let's use those CT scans to try to explore some other things. And poster 737, we're exploring those relationships with systemic inflammation because that study had a lot of inflammatory biomarkers. And we saw that also the fat quality related to metabolic syndrome. So in A5202 was a treatment-naive study. People were started on antiretroviral therapy, and 96 weeks later, they followed up. And of patients who were doing well and had suppressed viral loads on their treatment, we were looking at that subset of folks. And in those that group, the fat density, the less dense your fat was, so the more full of fat each cell was, the more components of the metabolic syndrome you were likely to have. And again, that's what we would expect. That's similar to regular obesity. We don't have the data yet on at the end of 96 weeks, if that's still true, but we would expect it to be true. And then what we saw was, the second part really was that controlling for the amount of fat, if two people have the same amount of fat and one of them has much more dense fat, that was actually associated with more inflammation.
Oh, wow.
So that's not the scenario we talked about earlier, where one person gains fat and loses fat. That's comparing, two different amounts of fat, and how has one of them become more dense than the other. And in that case, that's the fibrosis or the scarring and the inflammation that we talked about earlier. When fat is inflamed, cells, T cells and monocytes and macrophages, other cells of the immune system, move into the fat.
Oh, so that actually happens. You get T cells and
they go inside the fat, and
okay.
so they are more dense than the fat itself, and so the density increases. And so one way that density increases when it's not changing in quantity is by scarring and by infiltration of immune cells. And we have shown in another ACTG study that the fat under the skin, the subcutaneous fat, is fibrosed in people living with HIV. That's previously only been documented in obesity, but we suspected it would be true in HIV, no matter what your weight is, just because we know there's virus in the body. Your body is reacting to virus. In the fat, the way it would make sense for the body to react to virus is to try to wall it off and put it down some scar tissue. And so in the other ACTG study, 5317, we showed that when over time that fibrosis gets better, when you continue antiretroviral therapy, the body is able to heal itself. So in the current study, we might just be looking at that early period where the fat was really inflamed and more angry because it was seeing a lot of virus before people go on treatment. And it's possible that the people who had the most inflammation then had the greatest density of fat because there are more T cells, more macrophages, more scar tissue being laid down in their fat.
So would those, the T cells, the macrophages, would that tend to get trapped in the fat with the fibrosis?
We
or
believe
is it
that
still
when
able to traffic in and out?
They're still able to traffic in and out, and as the inflammation in the fat calms down, or as the stimulus for the inflammation, so as the amount of virus goes down with treatment, the cells should move out and the density should go down. And we do see that that's the trend that we saw with the data. We're going to go back to the original biopsies now that we've seen that trend, and we're actually going to stain the fat and look at it under the microscope and count the number of the cells to really prove our hypothesis that those cells are either coming in or moving out. And so we can really work out this mechanism of how fat is affected by virus specifically.
Interesting. Well, I'm fascinated by all of this, and I thank you. And I'm going to leave a little cliffhanger for next time.
Okay.
So it may or may not be true. Could fat potentially be a reservoir that may have application in cure studies?
I think absolutely. There's some early data, both coming out of the University of Texas and from France, that fat could be a reservoir. There's a lot more work happening. There's some really excellent science, and I think although there's not as many T cells in the fat as in the lymph nodes, say, where we think of other reservoirs, they're still there. And because we have so much fat, all of those cells add up and really could be a reservoir that we need to understand better.
Well, that's something we can leave for next time, and we'll explore that further. Thank you so much for talking with us and teaching us about something that is very complex.
Yes, it is. We're still learning about it ourselves, so hopefully next time we'll be able to explain it even better.
Thank you.
Thanks.